So what I'd like to talk with you today about is a recently completed trial. It's an observational trial, which was multi-center prospective, called the DECIDE trial, or does Ceribell rapid response EEG impact clinical decision making? This was a multi-center clinical study. Here are my conflicts of interest here. Does use of rapid EEG impact clinical decision making? And that was the formal name of the trial. And it was a prospective observational study. The authors of the study are outlined there, and really has a wide range of individuals. Dr. Daiwai Olson is a nurse, clinician and researcher. Dr. Hobbs, Dr. Sayana John, Dr. Westover, Dr. Bleck, and Dr. Larry Hirsch, from a variety of institutions which already use continuous EEG pretty routinely. It's kind of a wide area, academic medical centers for the most part in this particular study. So this was the study design essentially. So this was a prospective study, non-randomized, it's observational, basically everybody got this. It was actually two studies in one. Part of the study was a survey questionnaire of the clinicians that are using the EEG. So we, as the clinicians, were the research subjects. And then part two of the study are the actual patients, which were involved in this and could get consented for use of their data, their clinical data and so forth. And our main outcomes of the study were really time to getting the first EEG, getting this rapid EEG performed. The second was the change in patient in the physician's diagnostic assessment. What was their diagnosis? How confident they were in their particular diagnosis, and then what was the treatment plan, and what was the change in the treatment plan, and what was the confidence that they had the right treatment plan. And then we looked secondarily at ease of use of the system by essentially non-EEG technology people. Medical staff, and then we looked at any adverse events that may have happened with the device. And so the way that this worked and you can see it on the left part of the slide, was the patient would be assessed for some type of altered mental status. Usually this was in the emergency department or could be in the ICU, and oftentimes this is at these institutions as a resident or a fellow. And then saying, maybe this person's seizing, let's get EEG ordered. And they put in the order for the conventional EEG. They call up, that goes to the laboratory and so forth. And then they basically do this, They do this part where they fill out a questionnaire. It's kind of like a before questionnaire. What do you think about the patient? What's going on, et cetera? And then they set up themselves the rapid EEG system, which you just got done showing you. It's the headband that gets wrapped on the head, gets plugged into the device. There are a couple of things that you enter in a device and you put play and it starts monitoring. And then they look at it. They look at it both visually, and then the device has a seizure detection system in it. And when it detects the seizure, it makes a very grating sound, like it's kind of a funny kind of sound. And that's kind of meant to simulate what the old-fashioned EEG systems, with pen and paper used to make when a person was seizing. They would actually make that kind of sound. And then after they did EEG for a little while, 30 seconds of sound or 60 seconds of visual looking at the EEG, because it plays right on that little device itself. It's kind of like it looks like a smartphone. The physician would make another questionnaire. Well, now what do I think about this? And then then they would do monitoring, and the conventional EEG would get set up, and then the conventional EEG basically is going to get formally read. And these are the questions. At this moment, what do you think's going on? What's your level of confidence? Would you increase the dose of the anti-epileptic drug, anti-seizure drug, it really should be called? And what is your level of confidence about what's going on? And they would do that before EEG and after EEG. And this was kind of the setup here, 181 encounters with the physician, 37 physicians, and then 164 patient EEGs to be looked at. We lost a few due to various reasons you can see there for yourself. So that's the idea, timeline: consult, decision, questionnaire, rapid EEG, post-questionnaire, conventional EEG sometime later on. And that was the primary goal. Do you impact clinical decision-making, diagnosis, decision, to escalate anti-seizure meds, confidence in the decision, confidence in your treatment decision. And this was the group of physicians at various sites, years in practice, basically. Many of these were ICU fellows. Years in standardized EEG training. Many did not have EEG training per se. And then numbers of patients enrolled by each person at each site. Just a little more about the patients then, kind of different sites. It was pretty spread out across sites, so most sites were pretty evenly distributed there. Patients, gender, you can see, given anti-seizure medications, intubated patients, anesthetics, et cetera. So this is the clinical decision making. The suspicion for seizure. The suspicion for seizure actually, before the rapid EEG is done and then afterwards, it goes down because the rapid EEG is giving you quick information that no, this patient isn't seizing at this particular time. And whether or not are you going to escalate anti-seizure medication? You've given them something. Do you give them more? Do you give them less? Well, you can imagine if someone's thinking, well, they're still seizing, I'm not sure, let's give them a little more medication or not. What this device basically showed us is, in this study, is that it actually decreases the escalation rate after you actually get the EEG done. So more precise diagnosis and treatment decisions, and then confidence in the diagnosis. Remember, before they put the device on, they're asked, how confident are you? And then they're asked that again after you do this. And basically, confidence in the diagnosis and confidence in your treatment decisions basically goes up. And I think, it's you can read there, 84, 85% confidence rates, which are pretty good. So higher physician confidence in their diagnostic and treatment decisions. So this is again, accuracy of the EEG, sensitivity, specificity. All of these EEGs, both the rapid EEG, which was performed, and then the conventional EEGs, which were performed in those 164 patients, were post hoc and analyzed by 3 independent EEGers who were not part of that initial team at any one of those sites to read whether or not seizures were there or not. And in the pre-rapid EEG, the accuracy for diagnosis, you can see here was 64%. It goes up to 89%. The sensitivity for the diagnosis goes up. Obviously, it's pretty sensitive. And specificity goes up as well. And you can look at this as the physicians were relying on their clinical judgment alone. The physicians were relying both on the clinical judgment and the rapid EEG information afterwards. And so it improves that ability of confidence. And that's the kind of the before, your sensitivity and specificity for the diagnosis, for your clinical decision making, and then afterwards you see that both go up as shown before. Just a different way to show the same data, I like to point. So in these 181 patients, about 70% or so were empirically treated with anti-seizure medication. You can see 56% intubated, 39% were sedated. They were given some type of sedation, propofol, midazolam, et cetera. 22% of these patients were still seizing or had highly epileptiform patterns even after they were given this kind of treatment. And that was detected on the Ceribell device, the rapid EEG device. And that's when they were actually already on anti-seizure medications. So, and that's very similar to those early studies which we were just shown, or you're actually going to see this a little bit later, but those are similar to studies which already exist in the literature to say that people are continuing to seize non-convulsively even though their clinical seizures have stopped. And that's kind of the point. The point is that if you're just looking at the clinical pattern, you're not going to see this. And we know that about continuous EEG. If you don't look, you're not going to see anything. You have to put it on to be able to see the seizures happening. So again, the secondary goal was kind of the status quo, sorry, that's misspelled, of conventional EEG. How long does it take to get continuous EEG there? And so this is the timing here for rapid EEG. So remember, there's a decision here by the clinician at the bedside, they do a questionnaire, and then they put on the rapid EEG. And the questionnaire is pretty brief, so it doesn't take that long. Well, they start getting EEG in 5 minutes, essentially. That was a median. This is the interquartile range. And this was the number of encounters here. And you can see that by different sites, it was pretty similar site by site by site. Conventional EEG, that's where remember, if you thought you needed it, you order the EEG first. That call gets put into the tech. You do your questionnaire, you put on rapid EEG, right? So there's no delay in care for the patient because you've done what you would do as standard of care. Well, the delay is the mean delay here go back. The mean delay here is 239 minutes. So in these centers, which are academic centers, which conventionally do a lot of continuous EEG, it still took about 4 hours for the patient to go get hooked up. Part of that's the tech coming in, part of that's the call system, part of that's the patient is being moved wherever, whatever, they're going to get an MRI, whatever the situation is. But that's actually the delay that happens. And that is actually a lot better. And you can see site by site, some sites are quicker and some sites are not. This was after hour cases, 60% were after hour cases, and the number of technicians that are on site, et cetera. But it's about 4 hours. And that is actually a lot better than a lot of publications. There are publications of continuous EEG for acutely injured patients where the mean time is about 10 to 12 hours. And just because that's, people don't think of it as truly an emergency. It's an urgent thing, but it takes time. And our systems of care have that delay built into them. For various reasons. A lot of it is in not having enough people, technologists, to be on call and in the hospital and rapidly available, so to speak. This is the range at each center. This is the orange here is kind of conventional EEG. After hours is the darker orange. Working hours and after hours is the rapid EEG. And again, it's the scale here is a lot different. This is hours, 24 hours. This is 5 to 40 minutes. And so you can see the interquartile range there. This was pretty user-friendly. People were asked how difficult was it to do, how easy was it to do. Each were given about like a 45-minute instruction period as a group. They got to see how it would work, got an explanation. And then that was it. Then maybe some time later on, days or weeks or months later, they would actually go do this. So with that amount of training, they still thought it was pretty easy to use. We looked for skin problem. This device, when it goes on, it has a headband that gets wrapped around, and then there are these little discs that get twisted. And as they get twisted, they slightly abrade the skin and they put a gel contact. And they do that so that they get like the oil out of the skin and they get the hair out of the way. You don't shave anybody's head for this. Even if they have a lot of hair or a little hair, it doesn't matter, it goes on. And so we were worried about skin infection and irritation and so forth, and so that was not seen. And no real classical SAE or AEs were seen. So in conclusion then, our DECIDE trial investigators, we presented this as a formal abstract at the Neurocritical Care Society about 4 months ago now. The results are rapid EEG enabled bedside EEG within 5 to 6 minutes after that decision to do the EEG, and that basically avoids a several-hour delay. The rapid EEG informs clinical decision-making at the bedside and enhances physician confidence both in their diagnosis and the clinical decisions they're going to do. The rapid EEG was pretty easy and safe to use. So that ends the data part of the presentation.